Hello, everyone, and welcome to ACS Webinars, connecting you with the best and brightest minds in chemistry, live from Washington, D.C. I'm Michael David, and I am pleased to be your host for today's broadcast, which is being co-produced with the Science History Institute. The Science History Institute is based in Philadelphia and is the proud host of the Joseph Priestley Society Talk Series. The Institute collects and shares the stories of innovators and discoveries that shape our lives, focusing on the history of chemistry, chemical engineering, and the life sciences. The Institute houses an archive and a library for historians and researchers, a fellowship program for visiting scholars from around the globe, and an acclaimed museum that is free and open to the public. You can learn more about the Science History Institute and access an extensive collection of digital content from podcasts to other Joseph Priestley Society talks at their website. Today, we will be hearing from Dr. Este Geraghty, the Chief Medical Officer at the Environmental Systems Research Institute, more commonly known as ESRI. During this talk, we will learn how geographic information systems help inform data collection and responsive during the early days of the COVID-19 pandemic, and the continued efforts to end the pandemic, especially in relation to moving vaccines around the world. Dr. Geraghty has been with ESRI since 2004, where she leads the strategy and messaging for the health and human services sector, and has helped organizations from around the world use location intelligence to combat the Zika virus, finish the fight against polio, grapple with the opioid crisis, and combat homelessness, to name a few of her efforts. We also extend a warm welcome to Dr. Bill Trzynski, the program chair of the Joseph Priestley Society, who will lead the Q&A session at the end of our program. And now, welcome Dr. Este Geraghty.
Thank you. Okay, well, I really do appreciate the introduction, and I wanted to also say a special thank you to Howard Kravitz of the Joseph Priestley Society for inviting me to speak today. I'm actually pretty excited to share with you how geographic technology has been supporting COVID-19 response and global vaccinations in particular. Now, I know many of you may not be familiar with Esri or with geographic information systems, which we call GIS. And so I'll start with a little bit of background, and then I'm going to dive into the GIS and COVID-19 response story. At the end, I'm going to be really happy to take any of your questions. So please don't be shy at all. Just ask lots of good questions. So, who is Esri? Well, there was one Forbes writer that said that Esri is the rare business that has survived at least 5 tectonic shifts in technology and remains at the top of its game. I kind of like that one. You can imagine why, but it makes up for another fact about Esri, which is we may be one of the biggest companies that you've never heard of. So we build the world's most powerful mapping and spatial analysis software. And our offices do cover the entire globe, and we've actually been the market leader in this space for all of our 53 years in business. And we work with over 350,000 organizations, and that includes 75% of the Fortune 500. We have a presence in many national governments, every U.S. state government, most counties, and all of the most populous cities in the U.S. We serve over 50 industry verticals. That goes from retail to utilities and from conservation to health. Every day, more than 1 billion views of our maps and data sets occur, although through the pandemic, I would say that's closer to 6 billion daily views, and tens of thousands of new maps and data sets are being created all the time. Sometimes we call our work the science of where. Now, in fact, where questions are incredibly common. We ask things like, where's the problem? Where are things changing? Where should we locate a new resource? And if you listen closely, you are going to come to realize that people are always talking about location in one way or another. And it turns out, I did look this up, that the word where is the 110th most commonly used word in the English language. So I'd say where is a pretty important concept. Now, that concept of where is realized through the science of geography. Now, let's think about geography for just a moment. It's one of our preeminent sciences, right? It is truly the science of our world. Geography provides all of that rich content of our world, There is biological content, ecological content, sociological content. You pick your favorite ology, and it's uh, it's composed in our world, right? And that content is put into context using a common reference system that, by the way, all of us are able to speak, and that is geographic locations. The geographic lens, when we use it, it helps us to more easily see and digest complexity and relationships and patterns in data. And actually, I think it is our ability to assimilate mapped information that, at least in part, explains why people really love maps. Now, this geographic science, it really helps us to develop understanding, and it helps us to intelligently respond to all sorts of challenges. So then when we pair that science of geography with modern technology, the result is a GIS. So GIS stands for Geographic Information System. And like any information system that you would be familiar with, it uses computer hardware and software and tons of raw data to develop understanding and inform actions. That's what information systems do. But specific to this type of information system, we use it to explore the fundamental principle of geography, that location is important in people's lives. And in fact, at Esri, we believe that people can do amazing things with applied geography. Things like streamline their business operations, identify disparities and promote health equity, and improve overall health outcomes. This technology is designed to meld data with maps and apps to visualize and analyze our world and to find meaning in our data and to make smarter decisions, of course, as an end result. Now, the geographic lens offers a different perspective, kind of like a telescopic view of the world. And I think in health that we've gotten really caught up and maybe overly focused. Forgive me for those of you who are into bench science, but sometimes we are overly focused on the microscopic perspective. And we sometimes can forget that everything does happen in a context. So, what we need to do is bring these two views together, get the telescopic and the microscopic perspective so that we can develop a truly holistic and more accurate understanding of who we really are. Now, that telescopic viewpoint is important because when it comes to our health, it's been shown that 80% of our health outcomes are context driven. Our physical environments, our socioeconomic conditions, both of those influence our personal behaviors. And all of these things determine what our health status is going to be. And that puts a lot of emphasis on our communities because they create those contextual circumstances that have such a powerful impact on health. And although our communities can't curb our cravings, though I wish they could, they can craft the choices that are available to us. And certainly our communities can't change our eye color, but they can change our vision and the way that we see and behave in our world. When it comes to our health and well-being, it has been said that our zip code may be more important than our genetic code, but it's not a contest. The point is they're both important. Now ask yourself, what is the first step for a diabetic patient to be able to take their medications? Well, maybe having the transportation to go and get them. And we can use American Community Survey data to better understand where there are high proportions of households with no vehicle access. Maybe it's not the will to eat better that's scarce, but rather it's access to grocery stores with fresh and wholesome selections that truly are out of reach for some. Well, in our modern world, it is not hard to find out whether there are grocery stores available within a 10-minute drive time of a community. And while every community doesn't have a fancy gym available, we know that the population can flourish when simple sidewalks are available People need safe places to walk, and several cities have made that safety determination sidewalk by sidewalk. Now, consider this. It would not be unusual for a doctor to recommend that a patient get more exercise, right? I mean, I have done it myself many, many times, but as they make that recommendation, they may not realize that something like this could be that patient's reality. Having to walk along major highways, putting them at risk for injury or even asthma exacerbation from automobile exhaust. That doctor's recommendation needs to be grounded in context if it's going to be acted upon at all. A place definitely matters in health. This is nothing new. Hippocrates, the father of medicine himself, noted in 460 BC that where people live and the environments around them have a significant impact on their personal health and outcomes. So again, it's an age-old idea that's just recently coming to the fore. So why is that? Well, because without technologic support, it's simply too difficult. Okay, so how does this work in a technology world? So I want to start at a high level and then we'll dig in. We begin with simple questions about where things are located in the world. So where are the hospitals and the clinics and the labs and the pharmacies? Where are the patients, the community services, and even the health hazards that are affecting an area? Placing things in geographic space almost magically brings those things into immediate perspective. Then we can ask questions about what's nearby. How close are new mothers to WIC program services? WIC, you may know, is the Women, Infants, and Children program that aims to support low-income women and their young kids with nutritious foods. Here's another one for you. How much does COVID transmission increase in areas of high population density? That's still a nearness type of question that geographic analysis can answer. Now, in real life, we recognize that things are connected to other things, and we need to understand those connections to make faster, more accurate decisions. So, for example, homelessness can be connected to injection drug use. And both of these populations tend to use public restrooms with high frequency. Bet you wonder where I'm going with this. Well, the fact is, when you know the location of things, what's near them, and how they're connected, you're going to be able to make better decisions when, something happens to your network. Like in this case, a hepatitis A outbreak in the community. So hepatitis A is commonly seen in the injection drug user community, and it's transmitted by the fecal oral route, which is why public restrooms are of interest. So this is actually a real scenario. The city of San Diego understood all of these interconnections. So when they had a large hepatitis outbreak a few years ago, they quickly discovered the underlying cause. And as a part of their response measures, they mapped every public restroom in the city. They put them on twice daily cleaning schedules, and they added hand sanitizing stations to homeless encampments throughout the city. Now, this is a relatively simple, but I think extremely powerful example. The world, however, is not so simple as the graphics and example I just showed you. In fact, it is quite a bit more complicated. And I have to say, I think if we're going to improve our future, ensure health equity for all, and be more resilient to future health threats, we need to start looking at the world as one single ecosystem, appreciating and considering all of its highly interconnected parts. GIS helps us organize massive amounts of information and provides this framework for understanding and applying knowledge. I personally believe that despite Hippocrates and others extolling the value of place to health, we simply couldn't effectively apply that knowledge until the technology caught up. And in fact, it has, and just in time, if you ask me, given the complexity and the enormity of COVID-19's interruption in our lives. Now, I'm going to share with you how GIS has been a critical part of supporting pandemic response. And I'm going to approach the GIS and COVID story by covering three key areas of applied GIS, starting with map-based situational awareness, And then I'll highlight the analytics that improve understanding and planning with an emphasis on equity. And then I'll show how GIS is applied to engagement in a way that connects people to the resources that they need and publicly communicates up to date information. So I'll start by saying that there is no doubt that people have been getting their pandemic related situational awareness from mapped data. That trend began with the famous dashboard from Johns Hopkins University's Center for Systems Science and Engineering. Now, this dashboard, by the way, is the most viral map based application in history. It's been viewed trillions of times, unlike my Instagram account. So, let me make a few points about the importance of this dashboard. So, first, it awakened the world to health GIS in a pretty dramatic way. I mean, to be honest, it did in a few months what I have been working for years to do in my role. Now, next, the Johns Hopkins team prioritized data sharing. And that was a huge enabler for thousands of organizations who then needed to visualize and analyze and plan and make better decisions for their own local COVID-19 response. Now, furthermore, the Hopkins data, I think we all know, had exposed significant gaps in our various national public health systems, data gathering systems. These gaps were related to data collection and data sharing and data interoperability. And of course, a crisis always magnifies gaps. And the magnification of these gaps, I think, has been so profound that I truly believe we're going to see some real solutions on the near horizon. And finally, the dashboard, because of its regular updating process, they really built expectations among all of us for real time and near real time data. That has never been typical for health data. And I think that that too will and probably already has changed us and how we'll approach the timeliness of data going forward. And again, because of that open data sharing, others could simply consume the Hopkins data and create thousands, literally thousands of similar dashboards that provided near real time data for their very localized situational awareness. This has probably been the most valuable open data set ever created. And at Esri, our teams were also enabled by the Johns Hopkins data. So my colleagues created this weekly trends map, and it shows which way things are currently trending by county across the US. This is updated as of today. So in general, you can think of gold as a good sign. The arrows are pointing down, things are going down, and purple as a poor sign with the upward arrows showing increasing case numbers. So overall, the US trends look mostly good. This is probably related to or associated with things that you've read in the newspaper. But that one map cannot tell the whole story. This map tells us where each county is in terms of its pandemic phase. So pandemic phases are determined by the overall number of current cases per 100,000 population. So this is a totally different picture from the gold is good map. Most of the country remains solidly in epidemic phase, which is the worst of the WHO's 5-phase rubric. In this case, we need both maps together to appreciate that while things are going in the right direction in most places in the country, we cannot yet say that the crisis is over or that the infection rate is good by any measure. Now, of course, map-based dashboards went well beyond the display of cases and deaths from the Johns Hopkins data. The Africa CDC, as an example, is providing situational awareness, and they're doing it around vaccine delivery, the vaccine brands that are being used across the continent, and they're tracking the different variants of concern. And perhaps you've been reading about wastewater testing in the news lately. That's had a lot of stories. Now, the state of Missouri is just one example among many jurisdictions that are sampling their wastewater for SARS-CoV-2 viral shedding. Now, wastewater surveillance is a very interesting budding program at the CDC, and it gives us this new data point for community-wide disease surveillance. So very helpful as another part of situational awareness. So that map-based situational awareness basically gives us the lay of the land. Various types of spatial analysis, especially when we put equity at the center, starts to provide us with stronger evidence for planning and making decisions. And of course, if you want to do great analysis, it requires great data. So, one data innovation that we've seen in the pandemic has been the availability of anonymized and aggregated cell phone data from organizations like Unicast and SafeGraph. So their data is super interesting. It's been used to reveal social distancing behaviors, and it even shows visitation rates for different businesses like grocery stores, gas stations, and home improvement stores. I mean, this is how we knew that people were doing lots of home renovation projects during the initial lockdowns. These data provided great insights into human behavior that was really useful for guidance and for policymaking. So I want to show you a few examples of how this data was used. The first example, the social distancing behavior data enhanced the CHIME model. Now, you might recall reading about that model early in the pandemic. CHIME is a popular example of a mathematical model that simulates viral spread and makes predictions. Now, in this case, the predictions were to estimate hospital capacity problems from COVID-19 cases. Now, the original CHIME model was a global model where you would have one data point to account for social distancing behaviors and one to account for the rate of disease spread. So we enhanced the model by making those static inputs variable over space and time. So we could, I'm going to take a drink here and get back to this. Okay, that's much better. We could account for social distancing and disease spread differences over places and over time. So, really important, right? Because that allows us to make more accurate predictions so we can really look at which hospitals would be more impacted by COVID cases, when that was likely to happen, and how long that surge could last. And this was all about understanding and flattening the curve. So, you remember flattening the curve, right? So if I go back to this part of that little video right here, these are the curves, curves for hospital beds, for ICU beds, and for ventilators. So we're just going to look at the overall hospital beds in this case. So what if the total number of hospital beds available in Tennessee was 3,000, and we represent it by this line? So that would mean that between about day 87 and day 170, you would have more patients who need to be hospitalized than you have beds available. So that's going to mean that for 83 days, care would have to be rationed and outcomes would most certainly be worsened. So the goal would be to examine the areas of the state that are likely to have the most trouble, analyze the social distancing behaviors, and create policies that will start to flatten or push that curve down to below the 3,000 bed capacity line. Now, the other thing that this kind of analysis did was it helped decision makers to anticipate where they should go ahead and build more healthcare capacity, like converting convention centers into makeshift hospitals or increasing available hospital beds by stopping all elective surgeries. We saw these kinds of things happen around the country. Okay, hopefully you'll get a good view of this. It's a little video. It's an analytical application that uses that social distancing data. So here you're seeing every county in California represented over time by their social distancing behaviors. Red is an F and blue is an A. So we can put in the date that the California stay-at-home orders went into effect. Of course, before that, everybody failed. There was no social distancing. But afterwards, you can see it's sort of interesting. The coastal counties did a little bit better at social distancing than the inland counties. Of course, they certainly improved significantly from baseline. But then we saw something else happen toward the end of April. Social distancing was still in place, but people started to gather at the beaches. So why is that? Well, we can start to add additional data to try and come up with explanations. So we chose to look at the weather. So we pulled in a data service from NOAA and we built that up over the same time period. So you'll see that build now. This is what we call a voxel layer. So volume plus pixel, it's a voxel. So the darker orange brownish color is warmer temperatures. And of course, blues and greens would represent cooler temperatures. So now you can do this face-to-face comparison, checking for correlations between social distancing behaviors and weather. We'll focus in here on San Bernardino County. That is where Esri headquarters is. And sure enough, there is a very strong visual correlation between warmer temperatures and worsening social distancing. Although I swear it was not the Esri employees going to the beach. Okay, so another interesting, I think, analytic example that used GIS was for contact tracing, actually. Now, with GIS software, you can do link analysis. Well, that makes sense. It's a good way to understand the person-to-person connections. That's the traditional focus of contact tracing. So, okay, we can do that. But I would say maybe more important, we can add a twist to that traditional process, the traditional method. When you've collected location data in the contact tracing interviews, we can then start to take that data and put it to use. We use tools from graph theory, like centrality, to determine the strength of person to place connections. So just think about that for a moment. Sorry, my throat's getting me. Um, the person to place connections are especially important when you are in the situation we have been in for 2 years, right? Where you have widespread community transmission of disease. You need to understand the place contribution. Now, throughout the pandemic, of course, we being the global we, have needed to stand up all sorts of new resources in communities across the globe, like COVID testing centers, vaccination sites, and food distribution centers, to name just a few. Now, this workflow of site selection turns out to be very common and a very high value use of geographic analysis. So I want to show you an example with a simplified tool that we built for automating decisions about increasing vaccine coverage. So this workflow, excuse me, begins by all you have to do at first is simply collect and map the community's existing vaccination locations. So those could be hospitals, community clinics, or pharmacies, right? The places that make sense. Next, next, the user has to make a determination about what is an acceptable level of access to the community vaccination sites. Now, in some places, that might be a 30-minute drive time. In other places, it's a 15-minute walk time. It could be public transportation time. It's whatever makes sense for that local community. Once that's input, the first calculation the system does is estimates the percent of the population that can actually reach one of those current vaccination sites. So now the important part is working on the gaps, right? Those places where people don't have good access to a vaccine. So we begin by adding in candidate vaccination sites. And those are shown here in gray. And they could be anything. They could be parking lots for pop-up or drive-through clinics. They might be blood banks or schools or convention centers or any other place where you think vaccine administration could logically take place. Okay, so then we want to add elements of equity. And we want something that goes beyond what we already accounted for, right? Which is geographic accessibility. That's also an equity issue, but we need to add other variables. So we can include any factors that seem relevant for the specific population that we're doing analysis for. It might be age, race, population density, occupation, vehicle ownership, language, disability status, having available clean water for hand hygiene, comorbid medical conditions, or a host of other relevant indicators of vulnerability. So combine as many relevant indicators as you want, and the computer will create an index that weights all of these factors for the last step in the process, which is simply to run the tool. So in the end, what the tool does is it selects the fewest number of candidate locations, right? Think saving money, that would be needed to close the geographic gaps, while then favoring locations that are nearest areas of high vulnerability. Right, so this process works very well in places that have really good access to data. But you might be thinking, okay, well, how would we do this? This kind of planning, it's actually called micro planning in developing countries. Well, one thing that I personally love about geography is that it gives us options to make informed decisions. So, what you're seeing here is an example that comes from Uganda. Now, their road network data is pretty incomplete, mostly major highways. So, it would become a real challenge to determine a travel time in terms of accessibility to their vaccination sites. So, what we've done is divide the country into 1 kilometer hexagons. So, you're seeing those hex bins. And then we overlaid globally available data sets like elevation, slope, and land cover. So, when we have those, we can calculate for each hexagon a level of difficulty and therefore the time it would take to traverse various types of landscapes. So let me give you a couple examples. If you had a flat area with an impervious surface, like a road or a sidewalk, maybe it only takes 10 to 12 minutes to walk a kilometer. Whereas if you were in a forested area that had a steep slope, that was going to take considerably longer. So the point here is that no matter where in the world we're working, we can actually use geography to get actionable information, even if it's a little less perfect than full data availability. Now, through the analysis that we just covered, I've shown you how we could locate new resources or develop deeper understanding of an issue. And I think now the question is, how do you get people engaged? How do you connect them with the new resource or share the relevant information with them or even change people's behaviors? Well, of course, GIS can help with that. So I want to start with Locator Apps. Now, these apps have sprung up for all sorts of things. One of my favorites shown here comes from New York City. Now, their vaccine locator app not only shows the public where they can find the nearest vaccination site, but users can filter by the vaccine brand that they want and the locations that have open appointments on the days and at the times that they want them. And I know when you say it fast, it sounds really simple, but I wanted to just take a moment to let you know that to fully answer that question of where can I get vaccinated, it involves a lot. It involves integrating data for all the various vaccine venues, along with their characteristics like their location, their service hours, their phone numbers, the scheduling methods, and of course, the vaccine brand that they deliver. It also requires being interconnected with all the different scheduling systems that are being used by these organizations. They're different for CVS and for Walgreens and for your healthcare organizations and everybody else participating. Then, if we want to understand an individual's nearness to each venue with open appointments, well, of course, we need to integrate road network data as well. So there's a lot that's going on here to answer what seems like a pretty simple question. And most people, of course, will find their way to a vaccine when they want it. But some people really need the vaccine to be brought to them. Now, a health department could offer a simple survey that allows people to provide their address and opt in for a home vaccination. But it's important to also have a system for outreach to make sure that no one falls through the cracks. And there are actually several ways to identify who should be offered home vaccination, from national and local lists of people who are electricity and healthcare dependent to those who fall into geographic gaps, like people living in highly rural places or tribal communities. A health department may tap into several of these different options to identify all of the potential people who might benefit from outreach for home vaccination. Now, all of those various data inputs can feed into a dashboard so that call center staff can reach out and ask people if they would like to get vaccinated at home. Now, the call center can do all of their work from this dashboard. So to the right, you can see that they have a call script and a data input form. So it's all working together. As they acquire the information from that form, they get real-time updates in the map and the dashboard to show who is actually interested in getting the home visit to get their shot. So then we use GIS to further help in this process by optimizing the routing for the mobile vaccinators. So this really helps them to be more efficient with their time and resources while also meeting patient preferences because we can match up on things like language preferences. And the patients can get reliable visit time estimates so that they can better manage their day. We can definitely do better than the cable company on this one. Now, information for the entire process then can be reflected in an operational dashboard showing the whole progress of what's going on in this workflow, key performance indicators, and that way decision makers can take a look and they can make adjustments whenever they're needed. It helps them to be more agile. Okay, well, the last topic that I wanted to cover today is how GIS is used to increase vaccine confidence, or maybe if you're a glass half full kind of person, vaccine hesitancy. Okay, well, we started down this road very early in the vaccination process by creating this I got vaccinated story map. So I want you to please feel free to take a screenshot. I think this URL will appear in the chat box as well, because you may want to participate. This is a public-facing story map, and it's intended to reduce vaccine hesitancy by highlighting community members who chose to be inoculated. Now, this is me, and I added my story. You can too. It takes just about 2 minutes. And together, hopefully, we can continue to encourage people who are still on the fence to go and get their vaccine. And geography supports another kind of targeted communication for increasing vaccine confidence. We're working on this with the US CDC to combine localized information on attitudes, research data, lifestyle information, and the channels through which people like to get their information to hopefully increase vaccine uptake, certainly for COVID-19, but actually this program is for all vaccines. Went the wrong way. So here's how we're approaching it, or I should say how the CDC is approaching it. Now, the CDC recognized that there was a need for location-specific data collection. And to support a standardized approach, they published this version of a rapid community assessment in a guide last year. And it includes this rather lengthy and complex question bank that is meant to help gauge what communities are thinking about related to COVID-19 and what barriers are existing for them to having more vaccine confidence. So a paper survey, of course, is not very efficient. So we digitized the entire question bank with all of its various question types and the branch logic so that it then becomes much easier to deliver the survey and capture accurate data. Now, then the survey responses can be viewed and interrogated in a dashboard. And although this dashboard that I'm showing you is just a screenshot, just imagine that everything is interactive. So you could click on the bar graph, for instance, highlighting people who said that they were extremely likely to eat inside at a restaurant. And when you do that, the map would automatically update so you could see where that sentiment is predominant. Now, the next step would be to get to know a community with particular beliefs about vaccines so that you may be able to counter with education or targeted types of messages. Now, it's helpful to know the general demographics in a community, like their median age and income, the predominant languages that they speak, and even the general job types that people have. A relevant message for service workers may not resonate at all with white collar workers. So, in addition, you can use this kind of infographic to understand at very specific local levels the ways that people tend to consume information. I mean, do they prefer cable TV or a newspaper? Do they spend time on Facebook or on Twitter? And we can also use geographic information to recruit community partners who might be especially in touch with the locals. In this example, a public health department focused on an area with low vaccination rates is shown on the map. They might find great partners in the local hospitals and the pharmacies and the local faith groups. And there are many ways to use geography to support increased vaccine confidence. And so, honestly, what I've shown you today is really just the tip of the iceberg. So much of pandemic response requires location awareness. I've been busy the last 2 years. And if you would like to learn more, I do cover a lot more detail in my upcoming book. It's now available for pre order. And in this book, my co editor and I share the stories of innovation and triumph using GIS to solve pandemic related challenges. So you see, place matters a great deal in health, and GIS is the tool that helps us take advantage of that for location insight and doing better in our decision making. And now I will turn it over to Phil for questions.
The first, and I'm trying to do them kind of in the order, some sort of logical order. Um, how do you get the data that are used to build the models?
Yes. And it's almost predictable. Data is always the first question because we all love data. Um, so I'll take our
People are chemists.
Yes, a couple of different ways to think about the data. Esri actually curates quite a lot of data. We have around 15,000 data variables that we make available for purchase. They include about 2,200 demographic style variables, and then there are psychographic and behavior and spending data as well. That's one option. We also make available an open data site called the Living Atlas of the World. And that is curated data from Esri, but also from our partners who use GIS, like NOAA, like the US Department of Agriculture, like the CDC. And they take their data sets, make sure they're geographically enabled, and put them on that website. And you can really trust that data. It's got metadata and everything you would need to know for trust. The other part is this software is meant um, to make better use of your own data. So you simply need to incorporate your own data into the system. And it turns out that's pretty easy as long as it has some geographic reference. And then the last thing I'll mention is we have tools for data collection. So if that data set doesn't exist and you want to take on collecting it, we can help you collect geo-enabled data.
Okay, so it's really the users of the program who are responsible for generating and the quality control of the data then.
The quality control for sure, but we try to help by making sure that there are data sets with appropriate metadata so people can make good decisions, and a lot of free data. And when I say a lot, I mean along the lines of hundreds of thousands of data sets.
Okay, one of the other questions that goes along with that is there coordination between Esri and Google and all the data that they collect?
Not that I know of.
Okay, and,
Just leave it there.
all right. I assume that Esri uses satellite data as well as personal data. How do you collect personal, civic, and government data? Is it employees, contractors, or other means? Like, I think you sort of answered that, but
But let me clarify. Esri, we collect more population level data. Block group is the smallest level we go. We don't collect private or personal data on anyone or for any reason. There is organizational data that we have. But even at that, it's more where is the organization and maybe some key contacts or something at different organizations. So we collect more basic foundational data, but for some of that more detailed data, uh, we have not gone down those routes.
that obviously leads to the privacy question, how privacy is.
So it's a great question though, because for health data, you want to be extraordinarily careful that you are respecting people's privacy. not, for the good of people as well as respecting the law. And geography is an identifier, right? So if you're even using your own data, if you're a hospital or a public health department and you happen to have individual level data, you can still analyze it in a GIS system. But when you share your results publicly, you want to be sure that you have anonymized that data in some way, or I should say de-identified is a more appropriate term. And we have techniques to do that. So this isn't a lecture on how you do that, but I will say whether you're talking about aggregation or geomasking, which is simply randomly moving points in a way that preserves the spatial pattern, but totally de-identifies the individual, all things are possible there. So the privacy question is important, and we have taken many measures to address that and keep our software safe.
One question that's interesting is, are any machine learning algorithms used with the data, for example, by Johns Hopkins? And if so, how effective are they?
Yeah, so there are some interesting machine learning and artificial intelligence methods that we make available in the software. I can't answer for Johns Hopkins if they've used any of those. I can tell you that we've looked at a couple of really interesting things with COVID. One of them is related to predicting deaths, and I talked about how there was a bunch of emphasis on prediction for the CHIME model, and a lot of organizations were predicting death rates. But in the model, we use forest-based forecasting, which is a machine learning algorithm, and it does things like looks at the outcome of death, and you can look at how that varies over place and time, but it also gives you the importance of time lag. So I could tell you, for example, we found in the state of California that death rate increases significantly 13 days after a holiday. So Memorial Day, President's Day, whatever holiday weekend, people tend to get together, and 13 days later, the death rate increases. 9 to 14 days after increases in hospitalization rates, you'll see increases in death rates, and 3 to 4 days after death rates. So it makes sense as the death rate is higher, you're going to see higher death rates closer by that. So you really get this spatial temporal view of what's important and when it makes a difference. But yes, there are other kinds of artificial intelligence tools used for other parts of health and GIS.
A question on how does the software calculate accessibility? Do you have to enter bus schedules and routes?
No. So I guess the truest answer, it depends on where you are. In the United States, you're going to have a lot more luck with that. There are a lot of public transportation data sets that are fully available and geo-enabled so that you can pull into your analysis. We have, I think the most important thing for any analysis, though, and I think this questioner was really focusing in on that, is the underlying data. If you have underlying road network data with road speeds and directions and all of that important information that is accurate and updated, you can calculate accessibility. We've even done it for the scooters that people can rent in certain cities to estimate the travel time on those. So yes, you can do it with public transportation, but it's not available everywhere.
Well, we have a couple more U.S. questions. Going to step away a little bit, and someone's asked if you can give any examples of developing countries that have used the tool to increase vaccination rates.
Absolutely. I've written stories about great work done in Chile. Actually, they have a fantastic vaccination program. Panama did a great job with vaccinating their country, planning all of that effort using our tools. In Slovakia, they did amazing work using GIS to analyze wait times for testing so that people could pick which testing site they wanted to go to and not wait too long. But literally all over the world, we've worked closely with the World Health Organization, and some people may have heard me refer to a term called microplanning. And microplanning is really, we don't say that as much in the US, but that is the terminology used for how do we plan vaccine distribution at a community level. And GIS is a major part of that. In fact, there will be new documentation from WHO coming out shortly on how you do that step by step.
a U.S. question, and you may not have this answer at your fingertips, but is what percent of the U.S. is unvaccinated?
I don't have it at my fingertips, but too many, if I can say that. And I think it's important when you look at the numbers, and I can say you can look at the CDC, of course, has current information on vaccination rates. Uh, it depends on what you consider fully vaccinated. So I'm always disappointed when in the news I see that 75% of people have had at least one vaccine. I think actually the last I saw it was around 70%. Well, one one dose is not going to do it. It's not fully vaccinated. Why are you counting it? So you want to look at the people who have had at least a full course. Well, if that's with J&J, it's one dose. If it's with Pfizer or Moderna, it's two doses. But even then, we know that you've got to have the boosters at least 6 months after. So I'm only looking at the people who have had both vaccine doses plus a booster. And unfortunately, that's somewhere around between 35 and 50%, but not really close to 50. It's probably closer to 35%.
All right. Sort of a similar question, but well, not similar question, but in the U.S., medical specialists vary greatly geographically. Have you analyzed that, or can you analyze that?
You can analyze that. And in fact, I will give a shout out to Dartmouth. And Dartmouth has a program called the Dartmouth Atlas Project. And that project was created actually during the Clinton administration in anticipation of a national healthcare system. And so they built this whole medical atlas. And what they were looking at is exactly that. They were looking at variation in medical practices and outcomes across the country. So you can definitely look to their website. There's lots of data and information available there. I have done a study, I think it was focused on California, looking at differences in hospitals who used IVC filters for pulmonary embolism. So I've published on that, and the Dartmouth Atlas project makes it a mainstream effort. Oh, and you can also look to a book from Jack Wenberg called Tracking Medicine, and he writes all about that entire topic.
Coming around to a different direction, can you talk about how the algorithms are encrypted and to keep them safe from hackers and other breaches?
That's a good question. So I wouldn't necessarily say the algorithms. What I would say is it's more about the software and the protections of the software in general. And I am not our security officer, but here's what I know. Uh, if you use our desktop software, of course, and don't connect out to the internet with an open connection, obviously it's as good as your computer protections. Our enterprise software, it's the same way. It's as good as your organizational firewall and protections. When you're in the online environment, that's where you want to proceed with the most care. Our environment is considered FedRAMP low, but moving to FedRAMP moderate. It's actually FedRAMP low with some adjustment up. And so it works for federal government, including national security agencies with certain cares in place, as I mentioned before, with data privacy. But I'll also say, well, I did say we're moving toward FedRAMP moderate. The other thing to consider is mobile tools like the mobile surveys that I pointed out on a few occasions. Those are about encryption, and data needs to be encrypted in transit and at rest, and our software can do that for you.
Maybe you can't answer this one, or it's a whole other talk, but how can the medical community respond to misinformation?
Yeah, well, that's a good one. I don't know that I have all the answers. I would say it's not totally dissimilar from what the CDC is trying to do with the Vaccinate with Confidence program. It's about one, I think, there's a short-term battle and a long-term battle. In the short term, you can start to do strategic communications, as I pointed out, that the CDC is doing. I've also seen people create story maps. In fact, I think the WHO did this, showing the locations of misinformation and the news stories that came out, just pointing them out so that everybody can see this is not true. Um, so that's one way. I mean, that's sort of almost more interesting than it is useful. I think the long-term play, though, is to uh, have governments and the medical community be a bit more transparent and start to build up that trust with the communities that they serve. And many already are, of course, but I think we have a ways to go given the current climate in the country. And so appropriate transparency and communication, I think, is the long road to increasing that trust.
Okay, well, this is more a medical question for you, and I think with the time we're at, probably the last question. But it says in the study at Rockefeller University, antibodies were cloned. Is this a technique that can be used for future variants?
That is out of my realm. What I can say is in my realm is more the concept of how can we monitor and track the variants where they are, whether you're looking at wastewater or monitoring the genetic structure of the virus in different places over time. So that is being done. And we can look at flow from one place to another. But I'm sorry, the question is out of my expertise area.
Well, that's actually always a good answer. I don't know is if people can't say I don't know, can't be trusted, right?
Right.
All right. Well, thank you for your thought. Do you have any last thoughts or comments you want to make to the audience?
Sure. I just hope that everybody is starting to get it. Location matters, and it turns out it's a data point that's in 80 to 90% of our data already. So let's make use of it. I think we can do amazing things with geography.
Thank you for watching this presentation. ACS Webinars is provided as a service by the American Chemical Society as your professional source for live weekly discussions and presentations that connect you with subject matter experts and global thought leaders concerning today's relevant professional issues in the chemical sciences, management, and business.